Today's topic is applied physiology of hearing. Let us discuss it under the following headings: structure of cochlea, noise and masking, test of hearing, and loss of hearing and its treatment. Cochlea, it is derived from the Greek word cochleus, which means snail. It is a coiled tube around 35 millimeter long, which makes 2 3/4 of the turns. There are 2 3/4 of a turn is there, which looks like a snail. So this structure is around a central bone, which is called as modulus. Here you can see this is the bony part, which is called as modulus. So the base of the modulus is directed towards the external acoustic meatus and transmits the blood vessels and nerves to the cochlea. Up here to there. Cochlea is divided throughout the length by two membranes, that is the Reisner's membrane and the basilar membrane, into three compartments. The first one is the scala vestibuli, scala media, and scala tympani. So the scala vestibuli and scala tympani is filled with perilymph, and scala media is filled with the endolymph, which is potassium rich. Scala vestibuli, here also you can see this is the scala vestibuli, and this is scala media, and this is scala tympani. So scala vestibuli is filled with perilymph, sound vibration which enters the scala vestibuli from the foot plate of the stapes through the oval window. So this foot plate covers this window and is connected with the window's edges. So then scala media. Scala media is a space between the Reisner's and the basilar membranes and is filled with a potassium rich fluid called as endolymph. It is a closed space and is continuous with the membranous labyrinth. And then scala tympani, it communicates with the scala vestibuli. Scala tympani communicates with the scala vestibuli at the apex through the helicotrope. So this scala tympani is filled with the perilymph. Endolymph, it is the fluid which is present in the scala media or the membranous cochlea. So it is the endolymph is secreted by the stria vascularis. The composition of the endolymph is similar to the intercellular fluid. That is, it has rich potassium and low sodium concentration. Perilymph, it is a fluid filled in the scala tympani and the scala vestibuli. So it is similar to the extracellular fluid. In this, it has more sodium and lesser potassium. Reisner's membrane, or it is also called as the vestibular membrane. It separates the scala vestibuli and the scala media from each other. It is so thin and so it is easily moved. And then basilar membrane. So it is a fibrous membrane that separates the scala tympani and the scala media. It is attached medially to the osseous spiral lamina, and laterally to the fibrous spiral ligament. So this is the spiral limbus. Organ of Corti is a primary receptor of hearing, which is located on the basilar membrane extending from the apex to the base of the cochlea. It contains a series of electromechanically sensitive cells called as hair cells. Here you can see the outer hair cells, and here it is the inner hair cells. They are the receptive end organs that generate nerve impulses in response to the sound vibrations. Here you can see the pillar cells or rods of Corti. They are arranged in two rows of epithelial cells. Bases of inner and outer rows of pillar cells is separated by a space called as tunnel of Corti. Here is the tunnel, and it is filled with the cortical. Tectorial membrane. It is a thin, viscous, elastic membrane. It is a gelatinous matrix made up of glycoprotein. It is attached to the upper surface of the spiral lamina. It covers the rows of the hair cells. So the tips of the hairs of the outer hair cells are embedded here. So shearing force between the tectorial membrane and hair cells produce the stimulus of the hair cells. Hair cells, each is embedded in an epithelium made up of supporting cells with the base end in close contact with the afferent neuron. So the processes of the hair cells are bathed in the endolymph in the scala media, whereas their bases are bathed in the perilymph. So projecting from apical end or 30 to 150 rod shaped processes or hair cells. So there is a kinocilium. So it is true but non-motile cilium, one of the largest processes, and has a clubbed end. That is the kinocilium. Stereocilia, they have pores composed of parallel filaments of actin. So actin is coated with various isoforms of myosin. Along an axis toward the kinocilium, the stereocilia increases progressively in height. So along the perpendicular axis, all the stereocilia are same in height. Outer hair cell and inner hair cell. So here you can see the outer hair cell, and this is the kinocilium, and these are the stereocilia. Kinocilia and stereocilia. So the outer hair cell is 20,000 in number. It is a cylindrical shaped, which has 60 to 70 hairs. 5 to 10% of the sensory neurons innervate. 3 rows of outer hair cells lateral to the tunnel formed by the rods of Corti. It is concerned with the modulation of function of the inner hair cells. Inner hair cells, in turn, it is 3,500 in number, more rounded, or you can see the flask shaped with few course of hairs. So 90 to 95% of sensory neurons innervate the inner hair cell. So one row of inner hair cell medial to tunnel is placed. So it generates the action potentials in the auditory nerves. Noise is an aperiodic complex sound. There are three types of noises. White noise, it is a broadband noise which contains all the frequencies in the audible spectrum. It is used for masking. Narrowband noise, it is also a white noise. Here certain frequency above and below the white noise will be filtered. So it is used to mask a tested frequency in the pure tone audiometry. And the third one is the speech noise. So it also has all the frequency in the speech range between 300 to 3000 hertz. All other frequencies are filtered out. Masking, it refers to a phenomenon in which the presence of one type of sound decreases the ability of the ear to hear another type of sound. In other words, masking represents the inability of the auditory mechanism to separate the simultaneous stimulation into separate components. So the example of masking is observed as a difficulty in conversation in any noisy surroundings. So clinical application of the masking is clinical audiometry. One ear is kept busy by a sound while the another one is being tested. So masking of the non-tested ear is essential in all the bone conduction tests. So it is how it is used in the clinical setting. Hearing loss is a deterioration of hearing. Deafness is labeled when there is little or no hearing at all. The degree of hearing loss, according to the World Health Organization in 1980, they recommended on the basis of pure tone audiogram, taking the average of thresholds of hearing for the frequency of 500,000 and 2000 hertz. Causes of hearing loss, so acute exposure to a noise and chronic exposure to the noise. So there are two types of hearing loss. One is the conductive hearing loss. So it is a mechanical problem. The maximum conductive hearing loss is approximately 60 decibels. So any disease process which interferes with the conduction of the sound from the external ear to the cochlea, the inner ear, that causes the conductive hearing loss. So characteristically, uh, the conducting hearing loss is only partial and it is not never complete because the skull bones themselves they conduct sound to the cochlea. The bone conduction will be there, and the basilar membrane can be set into the vibrations. So the conducting hearing loss is always partial and never complete. And the second type is the sensory neural hearing loss. It is the damage to the sensory structure. So the hair cells, the auditory nerve, or anywhere in the auditory pathway. Here the hearing loss will be more than 100 decibels. This type of hearing loss results from the lesions of the cochlea, or that is a sensory type, or the eighth cranial nerve and its central connections lesions, that is the neural type. So usually loss of hearing is complete here. So another type of deafness, middle ear deafness, that is when there is a blockage or deformity in the pathway. So that is a middle ear deafness. Nerve deafness is when there is a damage to the auditory nerve. And then inner ear deafness when the cochlea doesn't function properly. Pathology of hearing damage. Conduction loss can be due to the air canal or the eustachian tube block, or it can be damage to the air drum. To there can be an infections or any puncture to the tympanic membrane, or even very loud sound can damage the tympanic membrane. These are all the conduction hearing loss, and also damage to the smaller bones. The ear ossicles can get arthritis or any infections that can also cause the conduction hearing loss. Sensory loss can be due to any nerve damage. Ototoxic drugs can cause any disease, can damage the auditory nerve or damage to the cilia. So noise, louder voice can damage the cilia. Twisting and swelling of the hair cells, detachment of the tectorial membrane from the cilia, reduction of enzymes and energy sources in the cochlear fluid, fatigue, that can also cause a sensory hearing loss. Otosclerosis, it is a hereditary disorder, bone surrounding the middle and inner ears that grows exclusively. So it is when there is a damage to the ossicles. So the bony structures, otosclerosis. This exuberant growth immobilizes the stirrup. So it will be difficult for the bony structures to move. It cannot transmit the sound properly. So it may develop in someone who had measles in their childhood. Ear infections. So it is commonly in the younger children. Otitis media. It can be chronic or acute otitis media. So infection may lead to the accumulation of fluid in the middle ear, especially the tympanic membrane. So chronic long-standing infection of the middle ear often results in both conductive and the sensorineural losses. Hearing loss is more likely to occur in children who have recurring ear infections. Autoimmune disorders. Autoimmune disorders sometimes cause the hearing loss. It may occur in people who have rheumatoid arthritis, systemic lupus erythematosus, the SLE. So cause of this is when there is an attack by the immune system on the cells of the cochlea. So it damages the cochlea. Drugs sometimes cause the hearing loss. There are They are called as ototoxic drugs. So many drugs has ototoxicity. Aminoglycosides, so most commonly implicated, particularly when given in higher doses. Quinine, so chemotherapy drugs, nitrogen mustard, aspirin, all causes ototoxicity. But the hearing can come back when the drug is discontinued. Mostly it will come back. Tests for hearing. So there are bedside tests, that is whispering, watch ticking, clicking the coin, and ticking of the nails. And there are other tests, Rinnie's test, Weber's test, Audiometry, pure tone audiometry, Otoacoustic Emission, and Evoked potentials. Test of hearing, voice test or whispered voice test. So ability to hear a whispered voice of 15 decibels from a distance of 2 feet is assessed. If the subject is unable to hear, the intensity may be raised up to 35 decibel and the distance can be reduced to 6 inches. So phonetically balanced words which are called as spondy, they are used like black, night, football, daydream. So which that has to be phonetically balanced. Finger friction test. So rough and quick method for screening. Thumb and the index finger are rubbed near the ear and the patient is has to appreciate the sound with their eyes closed. Watch test. So we have to bring the watch closer to the ear and find out whether the subject is able to hear the tick sound of the watch. So it is a rough way of finding the hearing deficiency. Tuning fork test. So tuning fork of 512 heads is used. Weber's test. So it is the base of the vibrating tuning fork placed on the vertex of the skull, and it has to be felt equally on both sides. So it is for the bony conduction. And then Rennie's test. So the base of the vibrating tuning fork is placed on the mastoid process until the subject no longer hears it. Then held in air next to the ear. So they hear the vibration in the ear after bone conduction is over. So then that is Rennie's positive. And then Sparback test, it is also similar to the Rennie's test. So we just have to add one thing, that is we have to compare the bone conduction of the patient with the normal subject. pure tone audiometry. It is performed in a soundproof room. Each ear is tested separately. Usually the air conduction threshold are measured, and also the bone conduction threshold are measured separately. So it is commonly used test. It emits pure tone in different frequencies. Subject listens it through the earphones. 6 to 10 tones of frequency between 250 to 8000 Hz are tested. Threshold decibels are plotted for each frequency in the chart. So this is the audiogram chart in which they plot the frequency and the decibels, how they conduct it. So it is used to find out the conductive and the sensorineural hearing loss. Otoacoustic emissions. So it is relatively new test which is used to assess the hearing loss in the newborns. A probe that contains both a tiny speaker and a tiny microphone is used. It is inserted into the air canal. So quiet tones are sent through the speaker which travel through the middle ear. It stimulates the hair cells in the cochlea. The hairs respond by generating their own minute sounds which are detected by the microphone. So if there is a hearing loss that occurs in the cochlea, they do not generate any sound. Brainstem auditory evoked response is a potential which is recorded from the auditory pathway in response to a brief auditory stimulation. So this evoked response, it assesses the functional status of the auditory pathway up to the midbrain. So there are waveforms in the evoked response. 5 types of waveforms are there. It is useful in assessing the hearing loss in the infants and small children who cannot respond properly. It is useful in localizing the brainstem lesions. So treatment for the hearing loss, we have to treat the cause, and hearing aid can help, and also the cochlear implant. Let us see one by one. So conservative treatment, so we can treat, and there can be complete or partial restoration of the hearing loss in the conducting hearing loss, like removal of wax, treating the infection with the antibiotics. If there is a damage to the eardrum, we can do tympanoplasty. And then next is the hearing aids. So it is useful for some extent in partial deafness because of problems in the middle ear and the cochlea. There are different types of hearing aids available in the market which can be kept outside, inside, everywhere in the canal. And electronic device that its main function is to they amplify the sound waves. And then cochlear implant, so it bypasses the non-functional part of the cochlea and delivers sound signals directly to the auditory nerve. functions by electrically stimulating the sensory cells in the cochlea. They can be used effectively by both deaf children and the adults. Books to read: Hindu Purana, Gaitan, Genong, and G.K. Paul. Thank you for listening.